Okay. So today I'm going to share with you a very unusual situation which happened with me, and this patient was a 88-year-old male patient, very high-profile patient, who was flown in from some 1,000 kilometers away and came to us for intervention. EF was 20% and had a previous angioplasty, bypass surgery, and so on and so forth. Multiple, admissions and complications. So he was admitted in our hospital with, for intervention. His angiogram was done. This was done outside, I think, and the right iliac was totally occluded. And so we had to go ahead with the left iliac side, and we had planned to do a supported angioplasty for this. This is the angiography which was done outside. And as you can see that this left, circulation is very, very, compromised, and the right artery is also occluded. But certainly there was one of the graft which was flowing, and the left main to LAD was very tight stenosis with heavy calcification. And he had a previous bioprosthetic valve, which you can see here. This is the graft which was patent to the right artery, but distally there was a stent which was also having some stenosis. So we decided that we'll first do the left main to LAD with the protected PCI using an Impella catheter. And then, of course, when we started planning to do the Impella, we also decided to check whether on the angiogram whether the rest of the aorta was okay or not. So it was reasonable. It was very heavily calcified. And we then thought that probably the best way to go is to go from the left femoral artery, and with a single puncture approach, where through the same 14 French sheath, we'll do the Impella and also the intervention. So here you can see that Impella went easily, and we were now doing the intervention, which was also going quite smoothly, and the lesion was crossed with normal, wire. And then, of course, first we did a cutting balloon in this, followed by a shock wave. And then, of course, diagonal was protected with the balloon. And here you can see a 314 stent being implanted after IVUS. And this is the post-dilatation using an open NC balloon, and you can still see that there was some residual which is being dilated with high-pressure inflations. And you can see that the IVUS did show a lot of calcification here. We do imaging in most of our cases. And this was after the stent. We saw that most of the stent is well deployed. There's some area which needs some more dilatation. So we did that dilatation. A second stent was also deployed distally because there was some small dissection. And the final result looked quite reasonable with no issues in terms of coronary. We were very happy that this case is successful, and in 10 minutes we should be out and no problems. But then what happened that the Impella would not come out. And in this 88-year-old gentleman, the Impella is not coming out. We had no idea what to do. And so we kept pushing, pulling, everything. Initially we thought that probably that Impella is getting stuck at the this valve, bioprosthetic valve. So we were not, we didn't find that because it did come out a little bit. And then it was not just coming out. And you can see that the whole aorta is porcelain aorta, where you can see that when we were pulling, everything is coming out. So at this stage, we thought, let us do a check shoot to see from the same sheath, because there was no other access. So we went through the same sheath, put the pigtail, checked that there was nothing which was really, obvious at the side except heavy calcific chunk at the arch of the aorta. So we decided that, okay, we cannot do any snare, because can we put a snare which can hold it? So basically at this stage we decided to take a wire to give some kind of a change in geometry to the arch, but that also didn't help. So at this stage we just thought that, okay, let us try a balloon to just give some support to this catheter. And here you can see that Impella is coming a little bit back, but it was not coming out. So then what we did was, after this second dilatation we did, and then tried to pull the Impella on this pillow of this balloon, and you can see that suddenly
Rupture.
came back, and then of course it was easy to take out everything. But this all took about 45 minutes to think as to what we should do, because taking out this impella was almost getting impossible, and there was no way to get any kind of surgical support for this patient to take this.
The last image, let me see the last image when you remove it.
Yeah, this is the last. You can see that this is coming out. Okay. Yeah.
Okay.
So now you can see that after this, then it came out quite nicely.
Fantastic. Now, any evaluation of that aorta after, or no need?
Yeah, so we clinically followed up because we thought that it can lead to some kind of perforation or injury to the aorta, but the patient was hemodynamically okay. That means there is no bleeding happening, so there is no rush to do anything more. So it is always better to just stay put if everything is fine. And this patient did very well after that.
Fantastic case.
Thank you very much.
Thank you so much. All right.